Hello everyone, my name is Waksman and I'm here with Mike Lincoff from the Cleveland Clinic. We are at the ACC 2014. Welcome, Mike.
Thank you. It's a pleasure to be here.
And you presented the very important study today. It's AleCardio.
Yes, AleCardio.
And AleCardio. Okay, why don't you tell us about the drug first and the class of the drugs and what was the expectations?
So this was a trial evaluating a drug called Aleglitazar, which is a dual PPAR agonist. So if you recall, PPARs are drugs that we use currently.
We have the ROSI and we have the PO.
Right. So so that's PPAR gamma. So the TZDs. So they modulate glucose metabolism. So they reduce glucose levels, improve peripheral glucose uptake, and reduce insulin resistance. Then the PPAR alphas are the fibrates. Then they reduce triglycerides, they increase HDL, they improve fatty acid uptake and oxidation. So this is a dual PPAR agonist. So it has both effects. And at least by biomarkers, these effects are ones you might expect to reduce cardiovascular risk. So we evaluated this in a trial of patients with diabetes who are high risk for cardiovascular disease by virtue of the fact they had an acute coronary syndrome.
And this was, I assume, a phase 3 study?
Yes.
Randomized trial?
Yes, so it's a phase 3 superiority trial. So we're all aware that the FDA since 2009 has required cardiac safety trials for new diabetic agents, but this was a superiority trial. So we were intending to actually reduce cardiovascular risk. The goal was a 20% relative risk reduction. So
and the control was just
standard of care. Yeah. So it was superimposed upon standard of care in a placebo-controlled trial. So it was multinational. It was
like
throughout the world.
15,000 patients.
Was 7,226 patients. Based on the event rate that we expected, it was around 6% the first year, and then 3 to 4% per year thereafter. So the intent was to go for 2.5 years.
And the primary endpoint was reduction of MACE?
With MACE being hard MACE, so death, myocardial infarction, and stroke. But the trial was stopped early. So we had intended 2.5 years of follow-up. At a median of 2 years of follow-up, the Data Safety Monitoring Board started to observe increased risk of adverse events. Now, these were not overwhelming adverse events. It was heart failure, which we know for the drugs of that class, reversible changes in renal function. They were starting to see bone fractures. We were seeing gastrointestinal hemorrhage, which had not been expected. And so they did a futility analysis. So they ordered a futility analysis. We had 55% of the endpoints by that point. It was an endpoint-driven trial. So they did a futility analysis to assess whether there was a possibility of benefit. Their point being that if there was going to be some ischemic benefit, then these side effects were not so severe as to preclude its use. But if there was no possibility of success, it was not appropriate to continue to subject patients to risk. The futility analysis showed less than 1% chance of success by that point, and so we terminated the trial in July of this year.
Now, the reason do you think that this was not showing any efficacy? Because there was a reason probably beyond the hypothetical or scientific rationale that it would be positive, right? You had some preliminary data. Was there any phase 2 study?
So the phase 2 study showed that the drug reduced triglycerides by 35 to 50%,
increased the HDL.
Increased HDL by 20 to 25%, and reduced hemoglobin A1C by about 0.6 to 1%. So these were all as good as or better than pioglitazone. And if you recall, in the proactive study, pioglitazone reduced cardiovascular events, and in 2 imaging studies, carotid and cardiac beds, IVUS, it reduced progression of atherosclerosis. So here's a drug. Now, granted, these trials with the pio were older. They were prior to the high-dose statins and routinely used. But nevertheless, that's pretty strong evidence that there may be some effect on atherosclerosis.
So indeed, when you looked on those parameters, they were performed, I mean, in terms of the drug performed, in terms of increasing HDL, reducing triglycerides?
So in AleCardio, hemoglobin A1C,
stuff, right?
So hemoglobin A1C compared to standard care was 0.6% lower. Triglycerides were 35% lower, and HDL was 20% higher. So by biomarkers, and this is again this disconnect between biomarkers and clinical outcome that we struggle with, but by biomarkers the drug certainly was effective.
So you cannot use those as a surrogates when it's come to diabetic optimal medical treated patients, right?
Which is why the regulatory authorities have been acting that way for now several years, and we in the scientific community recognize, and it's not just diabetics. I mean, what are we doing? All these lipid trials in other high-risk patients, and these each have to be proven in mortality and morbidity trials.
Although I did ask earlier this morning, I was talking with Steve Nissen about CKS9 inhibitors, if he would be willing to recommend it based only on surrogates without the outcome trial, giving all the data that was accumulated in this meeting, and he says, this is a special case because many patients cannot take statins, and maybe he would be forgiven on that part to use the surrogates without the clinical outcome.
Well, it's probably the best. One of the best. LDL is one of the most respected surrogates. Although obviously for ezetimibe we don't know if that holds. But I think the other thing that makes this such a special case is the magnitude of reduction. We're talking 50% reductions with PCSK9, which is so dramatic, unlike ezetimibe, which is 10 to 15%. That if it isn't a purely statin specific, then this effect, 50% reduction, should be effective. So I think, certainly approval for select populations and conditional approval on subsequent M&M trials, I think, is very reasonable for that class.
So, Mike, let me ask you, what's you think the future hold for all the PPAR gammas and PPAR alphas? I mean, you've seen all the way from Rosie to PO, and now to have the combined.
The fibrates with the difficult. Yeah, I think it's going to be very difficult for another development program of a new investigational dual PPAR. This is now the third dual PPAR to fail, furthest along by far. But these drugs are very complex. They activate genes in very unpredictable manners, so their side effects are very unpredictable, and therefore the therapeutic indices are very, very unpredictable. So, I mean, one can never predict, but I would be surprised to see another large development effort for a new PPAR agonist.
Okay, with that we'll stop now. Thank you very much.